Hello, class. Last class we covered chapter 2. I'm sorry, part 2 of chapter 4. Today we're going to be covering part 3 of chapter 4. And today we're going to be largely focusing our attention on the apical forechamber. So there's a few things that you need to be focusing on when it comes to the forechamber. Of course, at this point, we've covered the peristernal long axis and the peristernal short axis. So when you get the apical window, this is what the apical forechamber should look like if it's oriented properly. So you always want to find what we call the PMI, or the point of maximal impulse, so we can get the best view of the apical forechamber. And the way we do this is we should acquire the apical forechamber at that apical window, and we want to angle the transducer medial and superior towards the heart. A simple way of explaining this is if you consider the patient's left shoulder, if they're laying in left lateral decubitus, as 12 o'clock, so assume the patient's left shoulder is 12 o'clock. You want to turn the transducer orientation indicator marker to 3 o'clock or towards the bed. And you're going to have the indicator pointing downwards to the mattress or the floor. So when we look at the apical view, it should appear oblong and not rounded. And if it appears a little rounded, you should consider moving one intercostal space down, or AKA one rib space down, unless you believe that the patient has dilated cardiomyopathy. And we'll talk about dilated cardiomyopathy more when you get to path 2. But just know that it is a condition in which the heart's ability to pump blood decreases because the heart's main pumping chamber, which is the left ventricle, is enlarged and weakened. So you want to remember that in some cases, it's going to prevent the heart from relaxing and filling properly, so the heart is going to appear more round. But this is correct orientation with the right window, and also with it appearing kind of oblong, more oval than round. So you still need to know what you're looking at. Left ventricle, right ventricle, interventricular septum, your tricuspid valve, your mitral valve, your right atrium, your left atrium, and your interatrial septum. Always keep that in mind. Make sure that you know. These are numbered. This number 1 right here is your anterior tricuspid valve leaflet. Your number 2 is your medial tricuspid valve leaflet. Number 3 is your anterior mitral valve leaflet. Number 4 is your posterior mitral valve leaflet. Number 5 is your basal inferior septal wall. Number 6 is your mid-inferior septal wall. Number 7 is your apical inferior septal wall. Remember, number 8 is called your apical cap, not apex, but apical cap. Number 9 is your apical lateral. Number 10 is your mid-anterior lateral wall, and number 11 is your basal anterior lateral wall. Just keep that in mind. You kind of need to know your orientation when you're in apical forechamber. I have a short video here for you guys that gives you a tutorial on how to properly find the forechamber view.
So now we're going to work on finding best apical views. So I'm going to, again, put the probe down, and I'm going to do my circle survey, or I'll go window shopping and stumble into where the brightest image is for my apicals. This is a very nice apical view with a young person. And so I want to look at image composition here. If I had a bright right ventricle in my peristernal views, and now I have that left in my apicals, I want to get rid of that over brightness. I want to have good image composition throughout this field of view. So I'm going to back down my TGCs up there, and now I have a nice image again throughout. Sometimes the posterior is bright in the peristernal, and again, we don't want to have this in our image. We want nice image composition throughout the entire field of view. So I'm going to back off those distal or far field TGCs. We want to make sure that we have adjusted our frequency to optimize the best detail of the endocardium, as well as nice valve detail. You don't want to have too low of a frequency to see one thing when you're actually focusing on something else. So the highest frequency you can use is always the best way to go. So now I'm in a nice apical four-chamber view. How do I know that's a good apical four-chamber view? Well, I have a lot of experience. If I was seeing this and I'm bringing in the aorta here in the left ventricular outflow tract, that means I have two anterior of a four-chamber view. It's not truly the four-chamber view. Conversely, if I'm starting to see a vessel back here, this vessel is the coronary sinus, and it comes around in the AV groove, and then it drops into the right atrium. So if I see the coronary sinus, or I'm starting to see an opening on the interatrial septum from the four-chamber view, I'm too posterior. I need to make sure to angle more anterior to bring in the true four-chamber view. Also, it's very easy to have a foreshortened apical view. Let me see if I can find one in this case. Here's somewhat of an example. He's not so easy to get that on, but quite often it happens. You see the apex here is not sort of, you want the apex almost to be a point, kind of pinching off. Here, it seems to be coming in almost as if it's a short axis coming in. That means we're foreshortening the apex. So often then, here in this case as well, you need to find a lower window and angle steeper, angle higher up into the chest to open up the apex. So now you can see here is a perfect apical shot. It's almost pinching off there. If you look compared to the cursor, it's not coming in the way the sidewall is or the way the short axis does. It's nearly pinching off. That means we've got a nice shot of the apex. With no aorta, no coronary sinus. That means we have a good apical four-chamber view. Again, two anterior, the aorta comes in. We go towards the apical five-chamber view. Two posterior, coronary sinus comes in. And that means we're too posterior, and that's not a good apical four-chamber view. So that is the best apical four-chamber view right there. Often, when I'm working with students, I'll see a four-chamber like this. This is quite a good four-chamber. We've got the apex, very nice to see. The endocardium is very good. All the chambers are there. The mitral and the tricuspid are well seen. But notice that the whole heart is aiming off the screen the wrong way. We want it to be like this. Well, how do you get there? Well, look at my hand again. If the apex is pointing off to the right, I'm going to move my probe to the right. And now you can see I'm going more vertical now. So again, if the apex is pointing right, I'm going to move to the right. Now, if we're in this situation and the apex is pointing to the left, I'm going to move my probe to the left. And again, I've made the apex more vertical. So we've learned AO is too anterior, coronary sinus is too posterior, and how to orient the view if the apex is pointing off the right side of the screen, we move right. If the apex is pointing off the left side of the screen, we move left to get the perfect four-chamber view.
All right, you guys, that was a pretty good video just to kind of give you an idea of what you should be seeing when we get to lab. So I want to talk about a few things when it comes to the protocol. So you always want to make sure that you can see your septal wall and your lateral wall. If you cannot see them, that's a problem. You don't have a proper four-chamber. Remember, the doctor wants to see how well they're squeezing. We also want to be able to get the patient's ejection fraction and a bunch of things like that. I'll remind you guys, an ejection fraction is the percentage of blood that the heart pumps out every single time it beats. So you need to know that the left ventricular walls are going to be thicker than the right ventricular walls because they are high pressure and they have to squeeze harder to get all the blood out into the aorta and out the rest of the body. You want them to be squeezing concentrically during systole, meaning they're squeezing in together. But I want to draw your attention to some of these muscle pieces that look separated here and over here. We call those trabeculations. And whenever we do that trace, we want to trace around them. For like the ejection fraction, we're not tracing underneath them, but around them to the compacted myocardium. So during development, the heart muscles is like a sponge-like network of muscle fibers. And as like we progress and we develop in our mom's stomachs, the trabeculations become compacted, and the heart becomes like one muscle that's less spongy looking and more solid looking. And the trabeculations occur when that compaction does not take place. Usually, if you see it in patients, it's a patient who has what we call non-compaction cardiomyopathy, and most of the time their ejection fraction is like 40% or less. So I just talked about these numbers earlier. Just make sure that you try to memorize these wall segments. It'll help you out a lot. So the trabeculations I was talking about, this is what they look like. Right here. See how the muscles appear striated and they're like separated? They're not in one. This is what a normal myocardium would look like. And this is what trabeculations looks like. Also, if they have ejection fraction of less than 40%, they have non-compaction cardiomyopathy. So take a look at these muscles and take a look at this one. This definitely looks normal. These definitely are abnormal. So again, these are trabeculated myocardium, and this is a normal compacted myocardium. So one of the first measurements we make when we get into the apical forechamber is the LA volume. So we are going to be tracing from annulus to annulus. So from the anterior mitral valve leaflet to the posterior mitral valve leaflet, but we're tracing annulus to annulus. So again, what we're getting is the LA volume index. This red trace right here is what we call the forechamber LA area. This yellow line that we're seeing right here is the length. The arrows right here are the yellow arrow. It's an interatrial septum aneurysm when it's like bowing to the left. And so what we're getting here is the LA volume index. And the way they get that is they take the LA volume and divide it by the person's body surface area. And when we're measuring this, we're measuring is the LA enlarged. We're also paying attention to what this left atrium looks like. Is there a clot in there? Is there a mass that we cannot identify? We would also measure the mass separately. Is there interatrial septum bowing one way or another, indicating that the pressure is higher on the right side or the left side? Or does it have an aneurysm like this right here? This is the right side. So this could potentially be a coronary sinus or also an aneurysm, but I'm willing to bet that this particular one is a coronary sinus. So for the LA, remember that dilation can occur both with a person who has systolic and diastolic dysfunction. According to the ASC, or American Society of Echocardiography, they recommend that we use the LA volume index to measure the left atrium size by dividing the LA volume by the patient's body surface area. I said that earlier. I just kind of wanted to explain to you how we arrived there. And the LA volume and the LA volume index are what we call the biplane area length method. Is kind of what we use. And when we measure that LA size and the LA volume, we get what we prefer in echo over the linear measurements because it allows for us to more accurately assess that left atrium chamber. So for doctors and cardiologists, the relationship between like the person's particular cardiac disease is stronger. They can more easily diagnose the person when they have the LA volume than when they have the LA linear measurements. So the next slide here just shows a picture of how we measure this. So from annulus, we trace all the way around to annulus. This is apical 4-chamber. We get the length, and then when we get to apical 2-chamber, Again, annulus to annulus, from the medial annulus to the lateral annulus. And then the length again. Remember, this is apical 4-chamber. This is apical 2-chamber. So you need to remember these measurements have to be at the right time during the cardiac cycle. So whenever we measure the left atrium, it should be measured at end ventricular systole. So the ventricles are going to be the smallest, which will mean the atria are going to be the largest. We always want to make sure we're avoiding foreshortening by making sure we move down one intercostal space until it appears oblong and not rounded. So this trace that we're doing, what we call it in echo is planimetry. So when we perform planimetry or when we trace the chamber, we should not include the pulmonary veins, which are these, and we should not include the left atrial appendage, which is this right here. So we need to trace just the inside and leave out the pulmonary veins and the left atrial appendage. So when we measure the length, you want to make sure that you that's in the left atrium, and you're measuring the long axis. And the way we determine that is, it's the distance that is perpendicular. You measure from the middle, like so right where the valves close at, all the way to the posterior wall. So just keep that in mind. And the measurement is also going to be used in that formula that was shown like in an earlier slide. Okay. So this is more of what it's going to look like in your actual machine. Again, you trace to get the LA volume, and then you get the length, and they use that for the LA volume index by using that along with the person's body surface area. So apical 4-chamber looks like this. Apical 2-chamber looks like this. Now, this video is going to talk about how to trace the LA volume, all right?
From the medial annulus of mitral valve and then trace endocardium. Many patients, when you got here at this level, IV pulmonary vein is very prominent and go all the way. You don't go there. You just cut it and make it nice and don't include for the other. And even here, as you see, left auricle, you don't go there.
I need you to notice how he's leaving out the pulmonary veins and this left atrial appendage. This is debatable. I can see why he did it, but I may have cut mine a little bit smaller than that.
The number. And then you repeated the same technique for apical 2-chamber.
So this is for the LA. Now we're going to talk about the left ventricle. So we call this the biplane method of disc summation, but I'll talk about that here in a minute. For us, this is how we get the ejection fraction, or the EF. So remember again, the ejection fraction is the percentage of blood the heart pumps out every single time it beats. So to get the EF, we take the end diastolic volume and we subtract it from the end systolic volume. And then we divide that number by the end diastolic volume. So that's the formula right here. This is our preferred, by the way, we do this both for apical 4-chamber and for apical 2-chamber. Again, this is our preferred technique to measure left ventricular ejection fraction. We call it the biplane method of discs, or you can also call it the modified Simpson's rule, according to the American Society of Echocardiography. So again, we're measuring from both the apical 4-chamber and the apical 2-chamber. We always prefer, not us particularly, the doctors prefer for us to use a zoomed in view so that our tracing can be more accurate. And what we want to trace is the endocardial interface between the compacted myocardium and the cavity itself. In end diastole, and in end systole. We also want to make sure we have a clear endocardial border definition, as in here, you want to trace as cleanly as possible. If you have papillary muscles, you're not going to exclude them and trace inside the papillary muscles. They should be included in the measurement. Again, remember, if the papillary muscles reaches here, you don't start from in there. Even though you're not counting them, because the myocardium is what you want. You don't care about the papillary muscles. So if you are not foreshortened, you want to get the maximum LV area, the left ventricular area. Please avoid foreshortening, otherwise your measurements will not be accurate. So when you're approaching the mitral valve annulus, you want the contour to be closed, because when you go from here and you trace all the way down to here, your machine should automatically connect these two and close them. And then the LV length, which is this red right here, it's what we call a bisector, and it's going to be between the points of the apical cap and where the valves meet, if you have traced this correctly. So the next slide is just going to show an image of what that looks like. I talked about the formula already, so I'm not going to go back over that. This is what it looks like. Remember, you're doing it for diastole and systole. If you notice, if it's a papillary muscle, it's been included. Papillary muscle has been included. We don't care about it. The myocardium is what we care about. So this is the actual image of the biplane Simpson method, which we use again to measure the ejection fraction. So let me talk about what's normal and what's abnormal. What you need to know, don't worry about the volume for now. What's going to be more important to you is that number, the percentage. For women, the normal range should be 54 to 74%. 41 to 53 is mildly abnormal. 30 to 40 is moderately abnormal, and less than 30 is severely abnormal. These average numbers apply to men as well, not just women, all right? This other video that I have here is going to also show how to measure the ejection fraction. Just as a general rule of thumb, for both men and women, 55% or greater is considered normal. 30% or less is considered not good at all. It's bad. Like they need to go to the hospital and find out what is going on if they happen to fall under that 30% range. Again, this video is just going to show how to trace for ejection fraction.
Hinge or intermedial annulus of leaflet, and then trace endocardium. In tracing endocardium, as you notice in practice, there are many patients, they have prominent trabeculation, so don't include the trabeculation, cut them off, and just put over endocardium, as you see I am doing here. When we are dealing
it's a little bit cut off right here, so I would have made the sector a tad bit bigger, but nevertheless it's still accurate.
The wall thickness to this part compared to the other part, like here I am going cut the papillary muscle, and then
notice the papillary muscle is included in the chamber. He's looking at the compacted myocardium.
And then I finish it in the lateral hinge.
Annulus to annulus. Then it's going to connect it, and then this will be the length that's automatically received once they're connected.
32. Then in the same part,
that's for end diastole. He's now going to do end systole.
Systolic, that is almost correspond with the end of the T wave on the EKG, 1 frame before opening. And then again we go for the measurement. We start again in the medial annulus and trace endocardium here. As you notice, I cut some part of the trabeculation and papillary muscle, so I don't include them. And then I finish it at the hinge, lateral hinge, and then set. And here, based on the eye bodies correspond is 65%. Is that right? This patient is very young and healthy and athletic.
Remember again, anything over 55% is considered normal. This particular patient's ejection fraction was 65%, which is really good. So let's talk about TAPSE. But before we talk about what TAPSE is, it has a long name. That's why we just shorten it down to TAPSE. We've started trying to measure RV function, and that's a quick way of measuring RV function. So what we're going to do is, you see this cursor right up here? Direct your attention to this image for me, please. You're going to run an M mode, which is what this looks like when you turn on M mode, through the lateral annulus. That's the annulus right here, on the RV free wall. And then we're going to measure the peak systolic longitudinal motion of the tricuspid annulus from diastole to systole. So diastole, systole. So systole is when it squeezes, diastole is when it relaxes. So we're going to measure from here to here. That number is what's going to tell the doctor or cardiologist whether the RV is functioning properly or not. So let's talk about what TAPSE is. Again, we use it for general RV function, right ventricular function, mostly for RV systolic function. So TAPSE stands for Tricuspid Annular Plane Systolic Excursion. See how long that name is? That's why we call it TAPSE. And it normally is going to reflect the RV longitudinal function, but it also correlates well with measurements that estimate globally how well the right ventricle is functioning. We need to keep in mind that there's a potential to make an error here. So TAPSE can over or underestimate RV function depending on the sonographer that is doing the exam. So you have to make sure you're in the right orientation and the heart is not shortened and all that. You always want to make sure it's accurate. If it's measured properly, less than 17 millimeters or less than 1.7 centimeters means that the right ventricle is not functioning as well as it should be. So the next slide is an image of, just a better image of how it would look when you measure it on the machine that we have in lab. This is just me giving you an explanation that I have already given you. So right here, the lateral annulus of the RV free wall, that's where you're going to put the cursor and turn on M mode. Remember, the slope is not what you care about. The length is what you care about from end diastole to end systole. This person has 20 millimeters or 2.0 centimeters. That means that it is normal. Remember, normal TAPSE is 1.7 centimeters or greater, or 17 millimeters or greater. Abnormal TAPSE is anything less than 17 millimeters or less than 1.7 centimeters. So I have a short video again that's going to show you how to do TAPSE, just so it'll be easier for you when we get to lab.
Let's talk about how you get TAPSE measurements. First, you will need a good apical 4-chamber view, and then you select M mode on your echo. You place the M mode cursor through the tricuspid annulus, which is right here. So the M mode cursor would come just like that. And you want to measure the amount of longitudinal motion of the annulus at peak systole. So you place the cursor at your diastole, which is right there. You want to measure it to the peak of systole, which is right there. So what you're really interested in is the distance between systole and diastole, which is this. This table summarizes the normal TAPSE value. Anything less than 16 is abnormal, and anything more than 16 is normal. The numbers in the parentheses are the 95% confidence intervals. In this particular patient, we measure the TAPSE to be 2.4 centimeters or 24 millimeters. So that will be more than 16. So that is a normal TAPSE.
All right, you guys. So he says 16, but this is a bit of an older video. Just remember that number has been changed to 17 millimeters for when you go take your registry. So I want to talk about a few things here. When we've started measuring the RV as well, again, to check RV function, you should know that it's usually no more than 2/3 the size of the left ventricle. The left ventricle is normally larger. And sometimes you're going to run into trabeculations, which I've already explained earlier. But one of the things I didn't touch on is a moderator band, which you will sometimes find on the right side. This is what it looks like. And this is also what it looks like sometimes. So what a moderator band is, it's a thick echo-dense band that runs across the right ventricular cavity. And it connects the lower interventricular septum over all the way to an anterior papillary muscle. So it'll always look like this. I don't want you to think something is wrong. It's a moderator band. It's normally going to be on the right side. I have personally never seen it on the left side. So let's talk about these lines right here. You measure them, and if they fall under a certain number, it means that the right ventricle is normal in size. Usually they don't so much care about this length. They care about the width. Those are the three that are important. So the red line is the right ventricular mid diameter. The blue line is the right ventricular basal diameter, or the base of the right ventricle. This yellow long line right here is the longitudinal measurement or longitudinal dimension, but we don't recommend that anymore. So just these two are good enough. I'll talk about the numbers here in just a bit. So trabeculations, you're going to see them more often than not, and they can happen on the right or the left side, but usually they're more prominent on the left side. I need you to remember that. When a person has what we call non-compaction cardiomyopathy or left ventricular non-compaction, the ventricle is going to have bundles or pieces of muscles, just like I showed you guys earlier. And I need you again to remember that the person's ejection fraction, usually, in order for you to diagnose them with non-compaction, it has to be less than 40%. So you always want to make sure that you don't just say or you believe that something is. You can say possible. That way you can let the doctor decide whether it is or it's not. You don't diagnose. Remember, your job is not to diagnose. You don't actually do the diagnosis. You send a diagnostic study, but the doctor is the one who ultimately decides what that patient has. So in echo, your machine, these are the big ones right here. So this basal measurement right here, it should be less than 4.1 centimeters. According to your book, it's 25 to 41 millimeters or 2.5 to 4.1 centimeters. Don't worry about that 2.5. Just always know the cutoff numbers. What should it be less than in order for it to be normal? So this will be less than 4.1 or 41 millimeters. This should be less than 35 millimeters or 3.5 centimeters. I remember it better in centimeters because the numbers are smaller, so that works better for me. This longitudinal dimension, it should be 8.6 or less. If it's greater than 8.6, it means that the person has right ventricular enlargement. But again, you don't need to remember the length, because what's going to happen is if they have that enlargement, these numbers are also going to be wider than that. It's not going to be thin and long. It's going to be big and wide. So keep that in mind. I want to talk about ICDs. And this is what they look like, this supremely echogenic line you see right here in the right atrium and the right ventricle. So what an ICD is, it's an implantable Cardioverter-Defibrillator, and it's a device that detects any life-threatening rapid heartbeat. So this, if the heartbeat is abnormal, we call it an arrhythmia. And if it occurs, the ICD is going to send an electrical shock to the heart, and it's going to change the rhythm back to normal. Do not confuse that with what a pacemaker is. A pacemaker is for people whose hearts are not working, so the pacemaker sets the pace. So if your SA node or your AV node is malfunctioning, they will give you a pacemaker to set the pace. So the pacemaker is always working, but the ICD is different because it only sends a shock when it's needed to regulate the heart and try to keep that heart back in regular rhythm. So again, ICD works when needed. A pacemaker consistently works all the time. So just like how we did the LA volume, we're going to want to trace that RA, and it's going to look like this. So whenever we're tracing the right atrium, we want to make notations of a few things. Does this patient have an ICD or pacemaker? Does it appear smaller than the left atrium? Because it should. It should definitely not be bigger. And when it comes to RA volumes, some people don't have those numbers memorized. It would be better if you memorize the dimensions, because the volumes, most people who are working don't memorize the volume. Remember, it's going to be based on whether the person is a man or woman, and it's always more accurate. The volume measurements are more accurate than the linear measurements. So when we do planimetry, remember the word planimetry is a tracing. This tracing that we do is called planimetry. The right atrial area should be less than 18 centimeters squared, that you should remember. And the dimension should be, the major dimension is this length right here. This is the RA major, RA minor. Again, major, minor, area. So red trace is the RA area, blue line is the RA minor, yellow line is the RA major. If you ever see a dilated coronary sinus, which is right here, you should make a notation of that and make sure you get a good clip of it. By the way, this image is not in your book. I found it online and put it on there so you would understand what a dilated coronary sinus would look like in apical four-chamber. So when we do this trace, the next image just kind of talks about what that would look like for you guys in echo. These are both real echo images from different machines. Some machines look like this. Others give you this, but they don't give you the full trace, even when you do. Just remember that. It just depends on how new your machine is. So this is to assess the right atrium. We do it in the apical four-chamber, and it helps us estimate the right atrial area via this planimetry, which again is a tracing. So the first thing we're going to do is get the maximum lung distance of the RA from the center of the tricuspid valve, annulus right here, and then we trace that all the way down. The next, in the middle of the atrium, we're going to get a RA minor distance. We're going to measure from the middle level, from the free wall, which is this right here, to the interventricular septum. And you want it to be perpendicular to this length that you just did. Remember, the RA area is traced at end ventricular systole, which means the ventricle is the smallest, which means the atria are the largest. You want to exclude, do not include the IVC, the SVC, and the right atrial appendage. So anything that doesn't look like this, do not include it in the tracing. The normal area should be less than 18 centimeters squared. So for this picture right here, that's what an ICD wire would look like. Now this image is in your book, but I had a better image that I showed you earlier. Remember, if you have the coronary sinus, if it's dilated, you do want to show it. It's kind of another image right here. So some of you might be wondering what the coronary sinus is. The coronary sinus is a collection of veins that are joined together to form a large vessel that collects blood from the heart muscles, the myocardium, and deliver the oxygen depleted blood back into the right atrium. So I have a video right here that gives a bit more explanation.
Function at a recent conference I was at, so I'm just going to play the audio from that.
Now, there are a couple of different ways that you assess RV function.
Remember, we've talked about LV function. Now we're going to cover RV
shape,
function.
But the way that it contracts is really easy. It's basically just all one direction of contraction. The LV has like 3 different ways that it contracts, but the RV is pretty simple. So you can actually do easy calculations. This is the equivalent of doing an ejection fraction for the left heart. The ejection fraction doesn't work as well for the RV because of the shape of the RV. It's not a nice concentric like cone. The RV is this weird like a kidney basin. You know, the kidney basin that you have your patients throw up. It's kind of that shape. So it's difficult to get a good ejection fraction. So we do these things. We do S prime, which is systolic excursion velocity, TAPSE. This is the easiest one, so I'd focus in on this one. You can also do fractional area change. Let's talk about TAPSE. So the reason why we say TAPSE is because it's way easier to say than tricuspid annular plane of systolic excursion. So it's basically how well that tricuspid annulus is moving during systole. So you got your apical 4-chamber view. That's where you want to do this. And you're focusing in on this little thing right here. You're focusing in on what that annulus is doing. Is it moving well or is it not? You can eyeball this, but it's better to just measure it out. There's a binary thing. Is it doing well or is it not? This is a patient with some right heart enlargement, right? I mean, if we look at the ratio between this and this is at least 1-to-1, if not more than 1-to-1. But I'm wondering, is this an acute RV failure? I mean, it's definitely enlarged, but is this something that is acute? Is this shortness of breath caused by right heart failure or a consequence of a pulmonary issue that can be causing that right heart failure? So what you do is you stick your M mode transducer, your M mode cursor right over that annulus on the lateral border, and you'll get a waveform that looks like this. There's a bunch of different colors on here. You just want to pick one color and follow that color. You can definitely do the top to the top there. For whatever reason, I decided to do like this white line. I guess it was easier to find. And on most machines, you can just do there to there, and it'll actually calculate the distance for you. This patient had a TAPSE of 1.73, which is just above what we consider normal. If it's less than 1.6, that is diminished. If it's greater than 1.6, it's considered normal. I like binary things. I like when things are just black and white, yes or no. Systolic excursion, this is very similar. You're going to be doing this in the same area as you do TAPSE, but you are going to be using pulsed wave Doppler instead of your M mode. So it's the same thing, and you want your gate a little bit more apical than what you do with the TAPSE. The TAPSE is basically right on the tricuspid annulus, but you want this to be a little bit closer to the apex. And you're going to get this waveform, which is starting to look a little familiar, right? This is a similar looking waveform than the E to A. I have the E to A. They're actually down here off the screen. This thing right here, this is the S wave. And you're using tissue Doppler, by the way. And the difference between tissue Doppler and the other Doppler is that the scale is way less because the heart obviously doesn't move as fast as the blood moves. So they have to like tone down the scale. Otherwise, it just be this like little tiny blip down here. So you measure the peak of that S wave. And if it's 21 on this patient, if it's greater than 10 centimeters per second, the peak velocity, then that is considered normal. It's another way to measure it. You can actually do all 3 of these methods, or you can just pick one. They're just different ways to measure the same thing. Fractional area change is the last one. This is the one that's the hardest to do, so I do it the least, but it is an option. With this one, you definitely need to get, usually, the RV focused view. You see how it's kind of
notice how the trabeculations are inside and the papillary muscles.
In end systole and the area in end diastole. You do the biggest number minus,
they're not included, just the compacted myocardium
times 100, and you'll get a percentage. And if you have a fractional area change greater than 35%, that's considered normal. Less than 35% is considered abnormal. This is kind of the most cumbersome one, so I don't use it. But if you look at textbooks, this is just another option to do it. Most of the time I'm doing TAPSE first. TAPSE doesn't make sense or I want confirmation, then I'll do the S prime. And if for whatever reason I'm not getting a good answer with those, then I will do the fractional area change. And the AAC actually recommends doing all three if you are able to, and try and figure
All right.
function at a recent.
So I want to talk about color Doppler. We will also use color Doppler in the apical four-chamber. And on the right side, remember, in diastole, when the valves are open, you will not see any type of abnormality if the person has regurgitation. This is what it looks like when systole begins and the person has regurgitation. This is color flow Doppler for the tricuspid valve. This is a continuous wave for the tricuspid valve. Note that this is on the right side of the heart. This is on the left side of the heart. So in diastole, once again, you don't see regurgitation. This is color flow Doppler of a person that has, I want to say severe mitral regurgitation at this point. Even though it's not going into the pulmonary veins, it's definitely more than moderate. So if I was to report this, I would report it as moderate to severe mitral regurgitation. So I have better images of these. These are from your books. I just kind of want to show you a better image that I got from the internet. And this would be what normally it'll look like in four-chamber. And this is for tricuspid regurgitation. This is for mitral regurgitation. Remember, with tricuspid regurgitation, it is a disorder in which the valve does not close tight enough. And so the problem that happens is it causes blood to flow backwards into the right upper heart chamber, aka the right atrium, when the right ventricle contracts or squeezes. Mitral regurgitation, remember, right heart, left heart. Mitral regurgitation, which is also known as mitral insufficiency, is a common valve disorder. And when a person has MR, the blood leaks backwards through the mitral valve when the heart contracts. Now, this reduces the amount of blood that is pumped out to the rest of the body. So obviously, over time, this might become a problem. Well, that brings us to the end of part 3. I appreciate you guys, and we will start off with part 4 in our next class. If you guys have any questions, now would be the time to ask.